Perfect. So as you can see that the patient I have to show you today is a patient I did about a week back on 28th of October. He's a 61-year-old male, was referred to me with severe functional mitral regurgitation, heart failure, low cardiac output, lactates around 2.8, 2.9, creatinine 2.3, 2.4, systolic pressures around 70 to 80 systolic. Ischemic cardiopathy, post-MI, post-stenting, post-CABG, post-restenting, and this is his echo. You can see it's a functional MR, and the majority of the jet is A2P2, but more towards A1P1. It's slightly lateral. Can you see my pointer as well, right here?
Yeah, we can see that.
Yeah. So the
more central MR, right? A2P2 area.
Usually functionals are central,
yeah.
But this one is a little central, but a little canted towards the A1P1 as well. Just the junction of the A2P2, A1P1. Nice wide jet. So usually we put the patient under general anesthesia. As you can see, this is in real-time recording. I've not yet come by close to the patient. The TE is going on. Two views, we assess the MR. We do bicommissural. We put the explain on it and scan forward and backward to see the exact extent of the jet, the width of the jet. We calculate the reverse.
Size, severe MR, right?
Yes, of course, severe MR.
So I think that they looked at the parameters of the MR. What are the regurgitation fraction and all psi? You have measured it, right?
So this patient had a 126 ml regurgitant volume.
Okay.
And he had severe MR, pulmonary vein flow reversal was there. And he was sick. He was very low cardiac output, azotemia, lactate 2.8. So this is what we do first. Under fluoro, I use a micropuncture needle. I stick the vein on the femoral head. Once I stick the vein, there's a single perclose I use. Now, for the last 60, 70 cases, we're using one perclose for venous closure post Mitraclip. It's so convenient. There's absolutely no ooze. I don't have to reverse heparin.
Your adult cardiology are very rich. Actually, we use only figure of 8.
This Mitraclip, unfortunately, is an expensive
It works very
procedure.
well for the figure of 8 for venous. So, since you guys are rich, use a perclose.
Yeah. It's a 25 lakh clip. So you can see the perclose going in. Unlike the artery, I like to send the perclose all the way in, make sure I get the jet, then turn the paddle, pull it up. I'll just let the perclose part alone play. I'm going to start my timer. How much time do I have for this talk?
20 minutes.
Okay. So I've started the timer. So I'll keep 15 minutes considering I've been speaking for 5, so I don't overshoot.
We'll go on to the puncture side.
Yeah.
Oh, right. Okay.
So that's the perclose. So right after the perclose, I'm going straight to the puncture. Get the wire up. So what I do now is, now that I'm used to it, I want the puncture superior and posterior. Now you're most coaxial to the valve if you're inferior. But the problem is you need a certain amount of height to maneuver the clip above the valve. So you have to trade off between superior and inferior till you get anything between 3.8 to 4.2 centimeters. Because that's the correct height you need to be above the valve to make the maneuvers that you need to make to get to where you want to get. So you can see the bicom view. I actually, what I do is I rotate clockwise and pull down, coming all the way to the mid fossa. You can see the needle come. So once I'm in the mid fossa, I explain it, make sure I'm posterior enough away from the aorta. Then I go to fourth chamber and in fourth. So you can see the needle poking through. In fourth chamber, we actually measure the height of the indentation from the mitral annular plane. Sometimes when I don't get a good four chamber, if I go to this 158, I can nicely see the length of the septum between the annular plane and the indentation. So as you can see here, it was about 4.17 centimeters. The height looks perfect. So took the stick.
What's the minimum height you require for this side?
Muthu, usually functionals, I have a lot of luxury. I have big enough LAs, but when I have acute cardiogenic shocks with papillary muscle rupture and degeneratives that are caught new, then my LAs are still small. So I won't have the luxury of getting 4. So I might settle for 3.6, 3.7. Then you have to do additional maneuvers to get your height, like using the A knob and all. But to keep it simple, anything above 3.84 is very comfortable for the operator.
Okay.
So you can see the transeptal puncture is in. My sheath is in. I use 2 Amplax super stiff wires. I like to use the 1 centimeter floppy tip so I can take both into the pulmonary vein. So 2 wires in the pulmonary vein, sheath is out. I think because the puncture was so quick, my anesthetist is still double checking the measurements. But here we are. 1 pigtail goes in. This is extremely important for me because I like to have my continuous LA pressure while I'm doing the case. And the advantage of that is that there are a few steps we have refined as we have gone along. One of them is always 100% FiO2. The second thing is that even before my echocardiographer or anyone anesthetist realizes that I'm either denting the cord or moving the clip, I know what is happening by looking at the LA pressure jump. So the continuous LA pressure is invaluable for me in Mitraclip. So anyway, both the sheath is in, the steerable guide catheter is coming on the other sheath, the pigtail is in. Especially in these dilated hearts, if I'm pushing and I'm not able to get it in, what I like to do is I kind of straighten the sheath a little because the septum is more perpendicular and just pop through. As you can see in fluoro and in TE, you can see my steerable guide entering. Once the steerable guide is in, I take the wire out, take the dilator out, my axis is established. I like to keep about 1.5 to 2 centimeters in at this point of time. In this case, looking at the anatomy, we decided to take an XTW. Now, traditionally, so we're using the G4 Mitraclip system, and I have a choice between NT, which is the 4 millimeter wide, NTW 6 millimeter, XT, which is the 4 millimeter, and XTW, which is the wider clip. Look at the LA pressure, Muthu. It's 65, 67, the V wave. You can see the screen clearly, right?
Quite severe, yes.
Yeah. So high LA pressure, sick patient, 30, 35 LV, 30, sub 30 LV in the presence of severe MR. Steerable guide is about 1.5 centimeters in. Normally, for functionals, we take NTs because the XT can take so much tissue. You don't want to pull the leaflets in and rent on it. But in this case, I felt that the valve area was just right for me to get 1 clip in. Now, if I take an NT and I'm not able to get enough tissue and I have to put another clip to the side, my gradient will shoot up. So considering various things in the anatomy, we took a single XTW for this case. So you can see the clip comes in.
Basically, NT and XT are the length of clip. Clips have got two lengths, right? So XT is a longer clip for longer leaflets. And if you do it for a smaller valve, it can cause obstruction, right? That's what you mean.
Absolutely. So you can see the clip entering the LA. Now, at this point of time, I like to turn the guide a little posterior so I have as much space to clear. The important thing is here that I have to get these 2 markers to come in between this. That's called the straddle to allow all my levers to work optimally. But as you can see, as I'm going towards the straddle, I'm entering the superior pulmonary vein. The Coumadin ridge is here. I have to make sure I steer clear of it. So I go a little more posterior, give a little M, and as you can see, I've dropped down the Coumadin ridge. Did you see that?
Yeah.
So now I'm below the Coumadin ridge, but I'm very anterior. I'm on the aorta. I'm near the LA appendage. I'm very anterior. So I turn my guide posterior to go away from the aorta. And you can see that in real time. You can see my hands on the move, that I'm just turning the guide clockwise, which is going posterior. And I move away from the aorta, clear the cumedian ridge, clear the LA appendage, and I'm coming above the mitral valve. And then I'm giving the M, and you can see my clip bend towards the valve.
Yeah. The echo is very vital here. So I feel that echo cardiographer is a first operator here rather than the second operator.
It is vital. It is vital. But it's like two wheels of a cart. There's no first and second. The cart is useless without either of the wheel, Muthu. So here's the clip. I've kind of simplified the procedure. The minute I use short axis of base, I clear the cumedian ridge. The minute I come over the mitral valve, I want bicom, LVOT. In bicom, I see where I am, medial lateral, LVOT, anterior posterior. That's all I want to do. So as you can see, lining the clip up, what I want to do now is I want to get a nice perpendicular motion. When I move up and down, you can see my clip is getting lined up. I use fluoro and these two views. And can you see when I move the clip forward and backward, I want to be pointing towards the LV apex in both my views. So in both planes, I'm diving towards the LV apex, which means I have a nice right angle. So once I've established this perpendicularity, then I identify the jet. Muthu, you can see the nice white jet in bicom da. So I have to correctly bisect the jet. Now, once I've got my clip delivery system nice and perpendicular, I no longer give M or let go of the M, because once I do that, then I can't and dive either laterally or medially. Now, if I want to move, I move the whole system forward, or I pull the whole system backward to line up with the jet between medial and lateral. So that way, I'm still perpendicular in my point of approach towards the valve. So once I do that, open the clip arms. It's imperative that the clip arms are perpendicular to the line of coarctation. So as you go more commissural, it cants, and as you're more central, it's at 12 o'clock. So as you can see now, I'm in 3D NFOS. I'm adjusting the anterior posterior, so I'm right in the middle of the valve. And you can see the right angle also, right? Perfectly.
Yeah. Good. Yeah, I think
so it's lined up nicely. So I think the echocardiographer here was Balaji. Now all our boys have become very good. Ganapati, Balaji, Karthik, all quarterback this whenever we need to. So you can look at the clip, nice and perpendicular. Once I've got that, I open the clip arms, close it a little bit because it's a W, dive under the valve leaflets. I don't like to go too deep under the leaflets. I just go, you can see the clip is just below the leaflets. Once I'm there, I open the clip, reduce the gain. Again, check to see if I'm exactly bisecting the jet. So you can see both in bicommissural and LVOT, I'm right in between the jet. Okay, I've done 10 minutes, so I think I have another 4-5. And once I've got the jet, I'm opening the clip arms. And the beauty of this procedure is that there's no hurry. At this state, the patient is stable. You can see the LA pressures at 64. I have the clip right under the mitral valve apparatus. I'm free of all the cords. The minute I touch a cord while I'm moving the clip under, you will see my LA pressure jump. So it's now 58. It's actually coming down because I'm pulling the clip up and I'm bringing the valve leaflets together. And you can see how beautifully the leaflets are nestling inside the arms of the clip. And this is what I like to do. I like to get a slow, low dribble. I don't like them bouncing on the leaflets. I like to get a nice dribble. Even though it looks so good in the LVOT, can you see the orientation?
Yeah.
It's not perfectly perpendicular, right? Now, the problem, if you don't check before you close the clip, is that you can distort the entire mitral valve apparatus and your long-term results will be very poor. So even though it's looking so good here, I went to 3D enforce. I was not happy with the perpendicularity. So if you look at the fluoro, I'm gently rotating. I'm correcting the perpendicularity. You can see the cine. I'm gently correcting the perpendicularity while watching the LA pressure. So I'm not tapping any cord. And you can see my clip arms are becoming more and more perpendicular. You can see the leaflets nicely going in all the way to the base of the clip. And all my echo has to do now is just hold the view. That's it. Now I go back to 3D enforce. And I have to anti-clockwise a little more. Now that's perfect. So see what happens. When I anti-clockwise, my clip moves a little. I come more anterior. I'm losing the posterior leaflet. And because this is an ischemic MR with the posterior wall pulled down, you can see the PML is tethered and pulled downward. Muthu. Can you see it pointing downward? So it's, it's extremely important. I go under that PML and get that guy while I don't lose the AML. That's why I chose a wider clip in this case. So 3D enforce again. There's no hurry. 3D enforce again. And now you can see it's nice and perpendicular to the plane of coaptation. And double checking now to make sure that I'm exactly bisecting the jet, both in bicommissural and in LVOT. Then checking 3D enforce again, grippers down. Now you can see the dribble is gone once the grippers are down. Then I close the clip to 60 and I recheck all my parameters before I close. See, because these teeth are like shark teeth. They're like meat tenderizers on the clip. And these are all diseased leaflets. So until I'm absolutely sure that I'm exactly where I want to be, I don't close the clip. So now you can see I've taken so much of the PML that the entire clip is towards the PML. I close the clip nice and tight. Absolutely no MR. So at this stage, we know we've got a great grasp. All we have to do is check all the other parameters. First, I do the gradient.
The pressures come down, right?
Yeah, pressure drastic from 70, 69, 70, it's down to 37 now. MR has disappeared. First, I check the gradient. Then I mean, of course, first I look at the MR. Then I look at the gradient. I think looking at this, it should be about 2. I think Balaji is going for a little walk with the cursor.
Looks no grade actually. Looks like very nice.
Yeah. So 2 gradient. Then I look at the pulmonary veins. I look at the double orifice, look at the tissue bridge. Make sure I put color here. See that there's no jet coming from either in between the clip or from the side. You can see tilt right and left. Make sure there's no color coming in. Scan forward and backward. This is something that I really like doing, and I slept very peacefully after I started doing this. In the exact view, I measure the leaflet length before I put the clip. And after I put the clip, I measure the leaflet length that's outside. So I know at least 8 to 9 millimeters inside the clip. And that's the amount you need for the clip to hold very firmly, because these FMRs have volume overloaded LVs and they put a lot of strain on the clip arms. So if I have like 3-4 mm, it can actually peel off the next day morning, especially when I've used a wide clip like this. So that is done. I look at pulmonary vein to look at flow reversal.
You measure now the posterior mitral leaflet also length?
Yes. Posterior was no need to measure, Muthu, because I was already sticking to the posterior. Look at this. There's no posterior leaflet.
Yeah.
I've taken everything in because that's the one that's tricky. So once I've done that, look at that leaflet. I'm right at the posterior, and this is when the clip is really stable. So now I do the final arm angle, release the clip, take the spear out. And this is another nice trick I use. I make BICOM LVOT and I make my echocardiographer explain the clip. So at any point of time, I know where the spear is in both planes. So then I just move reduce all the curves, and take it out. That's it. So I can see it in both views. All the curves out, straighten the clips, take it out, trivial MR, no gradient, left to right shunt, and that's it. You can see left to right shunt with my pigtail in, measure LA pressure, measure RA pressure, do the hemodynamics, and get out. Thank you so much. I hope I did justice to that live in box. Muthu.
Thank you, Sai.
Class.
Very well demonstrated Mitraclip, Sai.
See, Muthu, the one more thing I want to mention is, if you look at the video recording, it's 1 hour, 6 minutes, unedited, from scratch to finish.
So quite a
Even
set.
before, so these cases are quite smooth and seamless. A, if you have a good echo. B, if you have an experienced team. And C, if you have enough case prep to start with. So a significant amount of planning, smooth execution. Thank you all.